Welcome back to Therapeutics. In this block, we're going to discuss some of the asthma management guidelines. Let's first start. Hopefully, you will discuss in ClinMed pathophysiologically what's going on with asthma and the things that trigger asthma. Our goals in therapeutics for asthma are a couple of different approaches we take, but one simplified way of thinking of our therapeutic goals and what our toolbox drugs are directed against are to address both bronchoconstriction with bronchodilators and also to reduce the inflammatory components of asthma. And historically, choosing just one of these two goals alone hasn't cut it. That we really have realized over the last 4 or 5 decades that bronchodilation alone, without dealing with anti-inflammatory modalities, is associated with increased mortality. And the inflammation alone the anti-inflammatories alone doesn't immediately address the bronchoconstriction that patients have. As clinicians, we have looked over the last 4 decades really to the National Institute of Health for guidelines for asthma management. And for a number of years in the past decade, the only available NIH guidelines from about 2012 or so, they did get updated quite significantly in 2020, in late 2020, but between 2012 and 2020, there were really nothing new posted in the NIH guidelines. And so clinicians began to look to other sources for guidance and updated guidance in addition to the NIH. And that often was from the Global Initiative for Asthma. And this organization has both more of a global approach to asthma management, but also had updated and continues to update their guidelines every year. And so what you'll find is that we are kind of straddling two sets of guidelines here for asthma management, where we will spend most of our discussion here and in ClinMed is primarily looking at the NIH guidelines from 2020. But there are a couple of circumstances where the GINA guidelines offer both maybe more current data, some newer evidence-based data, and also does a pretty good job at making it clear how to manage certain circumstances that clinicians will approach in asthma management. So for the most part, we are going to focus on the NIH guidelines on the left, but we will intersperse the GINA guidelines on the right-hand side of this graphic periodically, and I'll emphasize where that's going to be. So let's first start at some of the asthma guidelines from the NIH. And they have a couple of different sets of guidelines that you can look at via looking at the NIH website. And specifically, among other things, is their quick reference guide, as well as more specific information about their guidelines. In this quick reference guide, it's fairly complete. And it gives you pretty much the approach of how the NIH approaches it in fairly succinct way. So let's first start here is that they recognize and for the most part, GINA guidelines are virtually identical in most of these elements. The NIH looks at, on the initial visit, diagnosing asthma. How is that diagnosed? How do you assess severity? What medications might you want to initiate, and how do you assure patients know how to use those medications appropriately or demonstrate them back to you? They also recommend establishing a written asthma plan and having a regular follow-up. And then at each of those follow-up visits, this sort of approach of assessing, monitoring, tweaking medications, evaluating the response to those medications, and scheduling additional follow-up, this sort of cycle of how we approach many things in healthcare and our management strategies is pretty typical with asthma as well. So let's talk about some specific things that the NIH brings up. One is the things to think about for establishing the asthma diagnosis itself. So that should be based both on physical exam and also, particularly, they recommend for patients over the age of 5 to use spirometry testing to determine the degree to which the obstruction is at least partially reversible, and then consider any other causes or contributing factors related to asthma. The long-range goals, as we alluded to earlier, primarily are going to look at bronchodilation and anti-inflammatory modalities. But another way to approach this is to look that we want to reduce the impairment and reduce future risks. So reducing the impairment, meaning preventing chronic symptoms, relying less on short-acting bronchodilators, maintaining lung function, reducing their exacerbations, particularly requiring emergency room care or hospitalization care, and maintaining lung function to the extent possible. All of that while having minimal adverse effects to their therapeutics. As we look at assessing where patients are and monitoring how they're doing, we make that assessment, and the NIH gives you sets of guidelines on how to quantify that, and we'll talk about that in a couple of minutes. And then they also will recognize ways to evaluate asthma over time, how often that should be done, depending on where the patient sort of lands in their degree of control of their asthma. And then looking specifically at the modalities we have for managing medication with patients. One of the big concerns, or a couple of the big concerns with asthma management for patients are access to the meds because they're very expensive, and then technique, particularly as it relates to inhaled devices, the appropriateness of how a patient is choosing when to use which device, how they use that device, are they adherent with it? Is there a better way for them to demonstrate how that medication is being used for them, their technique? In addition to all of this, it's important to really engage patients in self-care and with shared decision making, and this happens even in pediatrics, but shared decision making and sharing with patients a specific asthma action plan. So making sure patients can handle their inhalers, know when to take them, know also of what oral meds they're on and how they take those and when they take them, assessing if there are any speed bumps for them taking their meds, financial or otherwise, and then making sure that the education is leveled appropriately for that individual and also gets reinforced at every visit. Asthma care plans are fairly consistent across most primary care settings. The type of written care plan often will be broken down something like this one. And what you'll see are what we consider often a green zone, a yellow zone, and a red zone. What we try to do with asthma care plans is not only talk in general terms that most patients who exhibit these kind of symptom or symptom-free status would be in the green zone, yellow zone, and red zone, but make it pretty specific for that individual. Whether or not a peak flow meter or some other way of evaluating their personal best for their peak flows or something else for a subset of patients makes a lot of sense for them to evaluate. Okay, my peak flow, my personal best peak flow is X, and if I'm at least 80 to 100% of that personal peak flow, I'm considered in the green zone, at 60 to 80% in the yellow zone, and below 60% of my personal best in the red zone. But you may also look at other symptoms that sort of bring you into those realms of yellow or red zone as well. Not only do we use this green, yellow, red light approach in asthma management, we use it for other conditions as well. Probably the other one I think of most often in the last decade where a similar care plan is written in a green, yellow, red zone might be the chronic care of patients with heart failure. where a green zone indicates that they're not in fulminant heart failure at the moment, and yellow and red indicate maybe they're holding on to more fluid, their endurance has gone down. They might be candidates for short-term diuretics and the like. In the red zone here with asthma, we're often looking at bolusing or pulsing corticosteroids with them, and maybe ramping up how often they use their short-acting bronchodilator. Other evaluations that are done per NIH, and this is true with GINA as well, are controlling the environmental factors or the comorbid conditions that trigger attacks for patients. That might be the kind of exposures related to allergens, irritants, pollutants, might be cold or jogging, exercise-induced kind of things as well. So all of those are important. Particularly critical that you make assessments of passive smoking, active smoking exposures, looking at socioeconomic determinants and lifestyle determinants of asthma exacerbations, which often are not in the control of the patient. And so are there, for example, allergens in the home environment related to animal dander or passive smoking or pollutants? Or is it a concern, for example, where there are carpets in the apartment that hold dander and allergens in them, and it's not easy or possible for the family to rip up those carpets? Or is it an issue that there are rodents in the area or insects or cockroaches or something that are triggering asthma? And so you'll be frustrated in practice when there are some of these exposures that, despite your best intent, the real answer to reduce this exacerbation is to get that individual living in a setting that is devoid of these exposures, but socioeconomically that may not be possible. So clearly frustrating, but you as a healthcare provider are going to advocate and help patients navigate to the extent possible the resources that are available to help them sort of maximize their health status with those speed bumps. There are a couple of specific circumstances as well that you'd want to be aware of in practice. One is the role of exercise in inducing bronchospasm. This is quite common, and sometimes there are patients for whom they have exercise-induced bronchospasm as the primary, and maybe almost the only manifestation of their asthma. And so when those are the circumstances, the role of making sure you reduce the risks for exercise-induced bronchospasm. If it's related to cold, can the patient wear a scarf or something? Can they exercise in areas where they're not having extreme cold to go out sort of running or jogging or walking, if that's even possible? Can they use the short-acting beta agonist in advance of their exercise, or are they more of a candidate for sort of upping before they start exercise or things they know are going to trigger their bronchospasm? Could they have a treatment plan that happens, 30 minutes before that's planned? Issues with pregnancy are always an issue for asthma patients. And what your goal is to go into that pregnancy with the best control in asthma possible and maintaining that throughout pregnancy. You want to be clear about which agents are maybe riskier or less risky. Usually we look at long-term inhaled corticosteroids preferred in pregnancy. Important about avoiding smoking for lots of reasons, but clearly that can worsen asthma, as well as fetal development, as smoking is an issue, among other things as well. A couple other things before we get to more specifics in the guidelines are how to manage exacerbations both at home and in the emergency department. At home, the care plan and making sure patients know in the red, yellow, and green zones where they are, what early symptoms mean, what they could do to prevent symptoms, or if they could preempt symptoms, when are they going to be a care candidate for pulse, corticosteroid therapy, and the like. We'll speak sort of near the end of this entire presentation about the GINA guidelines for emergent or urgent care, But in those circumstances, you're making assessments often in the emergency department or in primary care to defer them to or to get them into the emergency department when you know that they have significant hypoxemia. And while we are tolerant of uh, a blood, an O2 sat of 90, 91, 92% in folks who have COPD, which we'll talk about in the next major block. In asthma, any poor oxygenation than a 92 or 93 O2 sat, it becomes alarming for us. And so we really do want to be clear about how to manage, how to prevent those urgent or emergency care circumstances for patients, but also when they happen, how to triage that, how to manage that, how to get them in the appropriate setting. Okay, let's look at some of the specificity in the NIH guidelines for asthma care. First, starting with how do we classify severity and of someone's asthma, and how does that relate to what our steps in intervention are. This is a fairly busy slide, but what I'd encourage you to do as you look at this, let's first look at how the NIH defines intermittent asthma versus persistent asthma. And then for persistent asthma, we'll focus on mild versus moderate versus severe asthma. And so the elements we're specifically looking at on the left-hand side here are symptoms and nighttime awakenings, how often the patient is relying on using their short-acting beta agonist, or need something more than their maintenance therapy, and a few other areas as well. For example, does it interfere with their activities of daily living? Is there some correlation with their lung function, either in spirometry testing or as it relates to peak flows or something like that? Okay, so what you're careful about in these cases are not only what does that asthma control mean, but what are the risks associated with that? And then what are the intervention strategies? So we'll come back and talk, in a few slides from now about what the step therapies are at the bottom. We'll indicate what is step 1, step 2, 3, and beyond for adults and those over the age of 12, for those between the ages of 5 and 11, and for those under the age of 5. And we'll come in, the guidelines are quite similar with one major exception for how we approach asthma for the NIH scale as opposed to how the GINA guidelines approach it. But they're, for the most part, they're very similar in their approach. So intermittent asthma, when it happens on occasion, many times it's exercise-induced or triggered, but as this slide indicates, that we would consider intermittent as not very commonly occurring. We don't have problems with requiring short-acting beta agonists very often at all, and we have no nighttime awakenings and no real interruption in activities of daily living. In persistent asthma, we begin to see, based on age groups, differences in nighttime awakenings and also concerns for how frequently individuals would need to use a short-acting beta agonist, as well as whether or not that might have some influence in how they go about their normal day-to-day activity. You can see on a continuum, moderate has more significant issues where they're using their short-acting beta agonist pretty regularly throughout the day, or at least once a day on average, and they're also having more nighttime awakenings. In the severe case, we often see a significant amount of nighttime awakenings and almost regular use throughout the day of their short-acting beta agonist. All of those indicating some real problems with how that person's going to be managed. So as you think about those, whether it's intermittent, mild, moderate, or a severely persistent asthma, then you want to know, are they well controlled, are they not well controlled, or are they what we consider poorly controlled? So, well-controlled patients, similar to the kind of elements we looked at before, don't have nighttime awakenings, as you would guess. They have rare use of their short-acting beta agonists, and for the most part, they are doing well throughout the day. Anything other than well controlled is not good enough in asthma. So in not well controlled, these are folks for whom they would be candidates for going up a step or two, depending on where they are. That if it's not well controlled, we can do better. And we will focus in the stepped approach for therapeutics about when you fall into these not well controlled guidelines, sort of increasing things. In very poorly controlled asthma, these are often the patients who are in their red zones, that we need to do more than just look at adding another therapy, but they may need something right now. They may need pulse dose corticosteroids. They may need a further evaluation, depending on where they are and how poorly controlled they are. They might even require going to the emergency department for a severe exacerbation. But in the care plan, in the green, yellow, red zone plan, we often would have some self-management guidelines that before the patient gets to very poorly controlled, they know they're in the yellow zone and they have a plan of what to do before they get into this red zone in this very poorly controlled situation. So here are the NIH guidelines for stepped therapy, steps 1 through 6. And the role or the approach for this first will start with adults and children over the age or adolescents over the age of 12. And these stepped approach, typically we look at going up if they're less than excellent control, well controlled, and the possibility of stepping down if they've been well controlled for 3 months or more. You might look at going down the ladder as well as going up, depending on what their nature of their severity of asthma has been and how well they've been controlled recently, and if there's anything that is a known trigger that hasn't been addressed that triggers them. So let's start with step 1. For intermittent asthma, the NIH has for decades recommended only a short-acting beta agonist. If there is one major difference between the GINA guidelines and the NIH guidelines, this is it. Okay, and so I have a little fireworks icon here because this is really the major place where the GINA guidelines differ from the NIH guidelines. We've always, for years and years and years with the NIH guidelines, have given folks who have intermittent asthma, exercise-induced asthma, you start them on an albuterol inhaler, they're short-acting beta agonist, and unless they are having worsening control, we don't start inhaled corticosteroids until they're at step 2. That is not what the GINA says. The GINA guidelines are recommending that we give low-dose inhaled corticosteroid and a beta agonist. And in this case, the standard, even as a quote-unquote rescue inhaler, as well as a controlled inhaler, is often the longer acting, but probably of all of the long-acting beta agonists, formoterol has the quickest onset of action. Sort of as a practical decision, the inhaled corticosteroid low dose plus formoterol serves as the beta agonist, which is moderately longer than albuterol, but has a fairly quick onset, plus an inhaled corticosteroid for everybody. And the reason for that, the GINA guidelines are very specific at doing that. The next 4 or 5 slides go through their rationale. They look at a trial of almost 10,000 patients published in 2018 in the New England Journal of Medicine that looked at comparing as needed short-acting beta agonist with low-dose inhaled corticosteroids in conjunction with beta agonists and found significant improvements in folks who had the inhaled corticosteroid added on board. They noted that there were reductions in severe exacerbations. They noted reductions in emergency room visits and hospitalizations. And they noticed that overall patients had lower risks of severe exacerbations in the future when they used inhaled corticosteroid with formoterol compared to as needed SABA only therapy. So despite the fact that the NIH is looking at SABA only for intermittent asthma, many clinicians have adopted the NIH strategy, but just tweaked it a bit with, instead of SABA only, many clinicians are going with inhaled corticosteroids with formoterol at step 1 instead of what the NIH guidelines from late 2020 had listed here. The rest of the guidelines and the rest of the steps for adults and adolescents up to the age of 12 are quite similar to what you're going to see in patients who have Angina versus NIH. Typically at step 2, as we have to go up, folks are in less than perfect control. We look at adding an inhaled corticosteroid, often in conjunction with a short or moderate acting SABA or LABA intervention. And many times here we will add an additional therapy. And most often, while these guidelines look at cromolyn or theophylline, most clinicians will go to the leukotriene antagonists. And that has been long sort of the standard of care, is that leukotriene antagonists, and probably most often montelukast or Singulair is the agent you'll see most often used, is sort of the next step. So step up is using a inhaled corticosteroid for everybody step 2 and beyond. And because those folks may benefit also from using formoterol, a lot of clinicians will sort of merge the GINA guidelines and the NIH guidelines, that step 1 and step 2 have formoterol with inhaled corticosteroid. Step 1 is that formoterol plus inhaled corticosteroid low dose as needed, and step 2 is scheduled. Okay, that's the simple answer. And then adding one of the other agents on board, most often that's going to be a leukotriene antagonist. As you go up the steps, you'll see a very similar approach. You will see inhaled corticosteroid plus a LABA, and maybe even increasing the dose of the corticosteroid from low to moderate dose. And then if they're not on a leukotriene antagonist, adding it. What you will find is that while the NIH guidelines look at theophylline as an option in step 2 and 3 and 4 and beyond, many clinicians try to avoid theophylline because it's a narrow therapeutic index drug. In addition, the guidelines look at cromolyn as an option. We'll talk about that in a bit. But the problem with cromolyn is that it is clunky. It's cumbersome to use. You have to give it 4 times a day, usually by nebulizer. It's hard for patients to adhere to that. And it's really only going to be beneficial when it's given regularly 4 times a day for weeks on end before it offers any significant benefit. So it's not a common scenario. What you'll see also in steps 2 and 3 is if a patient has known allergies, it might be appropriate for sending them off to an allergist for skin testing and then immunotherapy for, they're allergic to, pick it, certain pollens, grass, whatever it is that's going to trigger their asthma, that they get desensitization to that program via an allergist as well. That's sometimes considered. Step 4, very similar, except all we're doing here is the same things we did in step 2 and 3, but we're continuing to increase the inhaled corticosteroid dose. Once you get to steps 5 and 6, you do all the things you've done earlier, but by this point, you are looking at high-dose inhaled corticosteroids. You're looking at LABA. You might be considering other modalities we're going to talk about in management of severe asthma that I think the GINA guidelines do a quite nice job at. But usually by the time you're at step 5, you are having that person seen by a pulmonologist. And usually it's the pulmonologist who's going to manage anything beyond inhaled corticosteroids and the long-acting beta agonist and the leukotriene antagonist. Anything much beyond that is usually going to be in the domain of the pulmonologist. Okay, again, and finally, step 6, all the things you've done earlier, but considering which of those other modalities may make sense. Okay? Similarly, in ages 0 to 4, the same kind of scenarios we see as we saw earlier in step 1 is SABA as needed in the NIH guidelines. If we look at what the GINA guidelines say, that they consider inhaled corticosteroids, particularly at the onset of a viral condition as well. And so they recognize even in these very young children that they might be candidates for inhaled corticosteroids. And then we look at very similar in ages 0 to 4, adding on low-dose inhaled corticosteroids and Singulair or Montelukast, and then going up on the dosing. You know, what's kind of missing in the age 0 to 4 is where we look at long-acting beta agonists. We don't look at this cohort, very young cohort, is getting long-acting beta agonists until they're all the way up to step 4. And just corticosteroids really is the major approach. Okay, you can see step 5 and step 6. And then again for ages 5 to 11 with the NIH, again, intermittent asthma, SABA only per NIH. And as you can probably guess, the low-dose inhaled corticosteroids would be used this anytime you are using a SABA, or, you know, is there a candidate for looking at formoterol with inhaled corticosteroid use even in this cohort. And then the rest of the steps are sort of a merge between what you see in older, above the age of 12, and those under the age of 5, is that we look at low-dose inhaled corticosteroids, but we will layer on, as soon as step 3, long-acting beta agonists and the consideration of cromolyn and theophylline, both of which I will say again are fairly limited because of their cumbersomeness of cromolyn and the low therapeutic index of theophylline. But again, by the time you're step 4, step 5, and step 6, you're very similar to what you see with adults. Okay? All right, there are a couple of tables here that have a lot of detail for which I would not have you focus on. I think what you would want to recognize is that there is a low dose inhaled corticosteroid, a moderate dose inhaled corticosteroid, and a high dose inhaled corticosteroid. And what that consists of depends on the corticosteroid and what we consider for the age group and the dose for each age group. So this chart and the one on the next slide sort of give you a comparison of those. But for the most part, I would not focus on it. Basically just thinking you're going from low to moderate to high. And this is data you can look up. You're also going to find that we almost never in adults would use corticosteroids alone, but use them in combination with a long-acting beta agonist. We never use a long-acting beta agonist alone. Although in pediatrics, for the earlier steps, we might use an inhaled corticosteroid without a long-acting beta agonist, and so these might be used alone under the age of 12. Okay, so you can sort of see some differences here. Just recognize that there are low, moderate, and high dose regimens. You don't need to know the specificity of these, I don't think, at this juncture. Similarly, comparative doses for a few other agents. Fluticasone is probably one of the more common choice agents you'll see here. There's a couple of different dose delivery systems, so the milligram strengths are a bit different. But again, don't fret about that at this juncture. Just know that it's going to be dictated in part by what's on the formulary of your setting. Okay, let's talk a little bit about some specific. In the NIH guidelines, a simple quick references are what are some usual doses for longer control meds. And we don't usually use fluticasone, formoterol in the very young patients, but there are some recommendations for standard dosing. And we very commonly use something like fluticasone, formoterol, or budesonide, formoterol, one of these combination inhaled corticosteroids with a long-acting beta agonist across the board once you're above the age of 5 in the guidelines. And here are some examples to that effect. The leukotriene modifiers, these agents have been around for a long time. For the most part, well used. They offer some what we call corticosteroid sparing effect. They are anti-inflammatory and are recommended usually across the board at step 2. A couple of years ago, there was some controversy about Montelukast or Singulair and whether or not it increased the risk for suicidal ideation. They sort of fell off the radar for use because for a couple of years people were a little concerned about that. I think that concern has largely abated, but recognize that there's still some lingering concerns about whether Montelukast itself is associated with any sort of significant adverse effect profile, particularly as it relates to suicidal ideation. I think as a clinician, though, most clinicians have found that Montelukast has worked very well, and most clinicians I've worked with over the years have never seen anything that would steer them away from Montelukast. It offers some clear benefit, lowers the risk for future asthma attacks, and is pretty easy to manage without a lot of drug interactions and a once-a-day dosing, even for young children. As far as immunomodulators, the NIH quick reference guide only refers to one, uh, which is the monoclonal antibody against IgE. But when we talk about the other immunomodulators and management of severe asthma, per the GINA guidelines, you'll see there's a couple of different choices beyond this one alone. It's just that when this was published in 2020, which is again the last time that the NIH sort of alluded to it, it was really the only major agent that was available at that time. Okay, as we continue to look at the agents in the NIH list of common other longer-term medications, they include cromolyn by nebulization. I will say that we don't see this used very often because to use a nebulizer 4 times a day is really quite burdensome for most patients. However, where you might see this used is for a patient for whom we know there is a large degree of allergic component to them. Their asthma is severe. They're already on a nebulizer, and this could be initiated 4 times a day. But it's a really burdensome type of intervention for the majority of patients, so you will not see it. The guidelines also look at theophylline. Our concerns with theophylline are sort of multiple, and most of the time, I do not see a lot of folks in primary care reaching out for theophylline because of the narrow therapeutic index. It could be a possibility to use for a subset of patients for whom using an inhaler is difficult. Where I usually see theophylline used, though, are patients who have failed other modalities and usually with the input of the pulmonologist. Theophylline has a lot of drug interactions with it. It can cause elevated heart rate, seizure risks, for folks who have an pre-existing cardiac history or seizure history or anxiety or insomnia, the like. All of those things, theophylline can sometimes make that worse. You've also got to be very careful about when you start certain antibiotics, particularly the fluoroquinolones or the macrolide antibiotics. Big interactions with theophylline, elevating theophylline levels, that can be problematic. So theophylline is a niche drug. I would say most often, most folks in primary care sort of leave theophylline to the pulmonologist. As far as long-acting beta agonists, we do not use them alone. They're only used in conjunction with inhaled corticosteroids. It's a little misleading, in fact, to have that listed here at all, because we would only consider using these agents in conjunction with an inhaled corticosteroid. And most often, for the sake of simplicity, we use a combination inhaled corticosteroid with a long-acting beta agonist and not one alone. We do have these agents, though, available alone, primarily for folks who have COPD, not asthma, for which corticosteroids in COPD are pretty much a later in the course of COPD management, where in asthma we give corticosteroids from the get-go for the most part. And finally, in the NIH common list of control medications, we'll see corticosteroids. Most commonly, this is going to be in the ambulatory setting, prednisone or prednisolone. By default, prednisolone is usually a pediatric drug, and prednisone is usually an adult oral drug. And then in the emergency department, most often by default, it's methylprednisolone. not as an oral tablet, but usually as an injectable. Okay, let's talk about some other specific issues in asthma care. One are disparities. GINA guidelines do a good job here sort of discussing it, and they notice that 96% of asthma deaths are seen in low to middle income countries where the financial burden of these therapies is problematic. And you will see across the board, these therapeutic options, particularly the inhalers, are really quite expensive. And unless someone has an insurance coverage that has an asthma benefit, then sometimes these asthma controlling interventions are quite pricey, and really people are making decisions of their asthma therapy or the housing or meals or something else. And so we see a lot of issues related to inequities, both in access to the medications and also the environments, which can trigger because of pollutants, because of animal dander, because of insect, cockroach manifestations and the like, are really see disparities in asthma care. And so important for us to recognize that. And part of our role is to look at where the barriers are for optimal asthma care and to do our best to sort of help that patient navigate the resources needed to well manage it. But it's a sad state of affairs when we recognize that these disparities are real, and sometimes as a clinician you feel your hands are tied about how much you can do to help improve it. The GINA guidelines also offer a couple other advantages in compared to what the NIH guidelines are for helping sort of frame the picture more easily, I think. I think the GINA guidelines for some of these things make the common standards sort of easy to look at. And while these are also some of the same things that are consistent with the NIH guidelines, GINA does, I think, a pretty good job at keeping both up to date on this and also making it easier for the clinician in the way they present it in their slide sets. And GINA particularly does a good job every year of updating and making their slide sets, to the point and available and accessible to clinicians. So in the difficult to treat asthma, they have a 10-step program. These are patients who you have gone through those steps, NIH steps, or GINA has similar steps. We won't focus on those too much. But you've done that and you still find that there are other things you want to think of. This patient's not responding in the way you would have thought they would have. So they have a couple of approaches to take. First of all, to confirm you've got the right diagnosis, number one. And then two, look at factors that might contribute to exacerbations. Poor quality of life. Is it inhaler technique? Are they not adhering to things? Do they have comorbidities that make it problematic? One of the big ones is gastroesophageal reflux. Obesity is sometimes an issue as well. What are modifiable risk factors in the environment, if that's possible to manage? Are they overusing short-acting beta agonists? Are there other meds that are triggering bronchospasm? For example, are they on beta blockers? Is anxiety or depression contributing to their asthma presentation as well? Okay, so all of those important as you think about, gee, this person's not responding the way I would have liked. You also then look at optimizing management, so asthma education. You optimize the treatment options to know how to use their inhaler, what non-pharmacologic things are appropriate, smoking cessation for the COVID vaccinations. Are you treating comorbidities appropriately? Are there other non-biologic add-ons, particularly leukotriene antagonists? Are they candidates for a higher dose inhaled corticosteroid if that isn't already on board? And then you're sort of continuing to look at, is it still uncontrolled? And if it is not uncontrolled, then stay where you are. Maybe they're even candidates for stepping down. But if it's poorly controlled or uncontrolled, then you sort of go on to considering this more severe asthma, and then you go to sort of the next steps. So you've done your homework already in the standard guidelines. You've looked under rocks for comorbidities. You've made sure folks adhere to the therapy. Still problematic. Okay. So then you want to consider or look at a couple of other options here. And they list some other considerations. What are the kind of testing do you want to consider? Do you want to consider their, allergy screening? Do you want to look at their blood eosinophils? Do you want to look at their sort of other variables, as maybe you're beginning to think, hey, I need to get this person seen by the pulmonologist. As you're assessing their asthma, could they have what is considered a type 2 inflammatory state? They have elevated eosinophils. Their Fe nitrous oxide is elevated. Their sputum eosinophils are high. There's allergic component to their asthma that's significant. And in these circumstances, if that's happening, then you sort of take a different approach. So if they don't have type 2, then you're reviewing all the basics you've already talked about, and you're considering whether or not you want to maximize any of these add-on therapies, making sure they're using their inhaler, the environmental things haven't changed, all of those. If, however, you think it could be type 2 airway, then you're considering, are they adherent to therapy? What other options can you consider? Can you look at an add-on type 2 targeted therapy for the patient that's there, including, in addition to the type 2 targeted therapies, which can be expensive and may not be covered by their insurance, you also look at, can you maximize inhaled corticosteroid or other leukotriene antagonists if you haven't done that already? The add-on therapies, though, for type 2 are pretty specific, and they vary based on what are going to be covered by insurance. These modalities are expensive. They often fall under the realm of the pulmonologist, but even if you're not working directly with the pulmonologist in their clinic, you're not going to be a pulmonary expert as a provider, you still want to sort of set this patient up when they go to the pulmonologist. So what I think the GINA guidelines do is they look at sort of 4 targeted areas that fall in the domain of the pulmonologist, and they kind of lay them out pretty well. So do you want to look at, or is this patient a candidate for a monoclonal antibody directed against IgE, or interleukin 5, or interleukin 4, or sort of alternate therapies? And these are some initial predictors on the right-hand side of this slide of who is more likely to be a candidate and respond better to one or another. This still falls in the domain primarily of the pulmonologist, but it may have to do with assessing nitrous oxide. It may have to do with their eosinophil counts as well, about who may or may not respond to therapy. If they start one of those therapies and then you look at every 3 to 6 months, evaluating their response to therapy, that's usually done in conjunction with the pulmonologist, and then considering which therapy makes sense for how long. Do you want to consider a trial of coming off of it after they've been on it for a while or not? In reviewing responses over time, if they've had a good response to that type 2 targeted therapy, they get it reevaluated every 3 to 6 months. And the pulmonologist in that case often will consider whether or not this patient's a candidate to trial off of it and try other therapies or not. But that's usually some considerations that happen. And if they don't get a response to that type 2 targeted therapy, they may be a candidate for a different one. And again, that really falls in the domain of the pulmonologist. Finally, optimizing their regimens, making sure you haven't forgotten the basics of adherence, technique for inhalers, managing comorbidities, all of the psychosocial things that are triggers for asthma, and making sure that the shared decision-making as well. The last area we're going to spend a little time talking about is the management of an emergent state in asthma care. And again, the GINA guidelines do a pretty good job with this. I had some early and non-copyright data. I did pull this from the GINA's website, which you could see as well. But I think because for academic purposes, usually even though these are do not copy or distribute, when you're talking about academic use, that's usually pretty free reign. But I defer you to look at the GINA guidelines specifically for this. This guideline is a over 100 pages, 150, 200 page guideline, but they do a nice job at walking through an acute exacerbation in primary care or in urgent care. So in primary care, as you walk through this algorithm assessing the patients, is it moderate or is it severe asthma? And the things I think you're important to recognize is, what does severe asthma look like? Often you will see words, not full sentences. The patient has posture that, hunched forward. They really have pursed breathing, difficulty using accessory muscles to breathe. They're often tachycardic. Their O2 sats have fallen. Anything below 92% is kind of concerning to us in asthma. And those can really become problematic because very quickly these patients can tire out, get drowsy, confused, and then that patient will need intubation. If it's mild to moderate, though, in acute primary care, we often give very high doses acutely of their short-acting beta agonist. So 4 to 10 puffs repeated every 20 minutes for an hour. And we start them on pulse prednisone therapy, and you might have them on oxygen therapy as well. Okay, and that can be done in an outpatient setting, but if things start to tank quickly, you don't hesitate to get that patient in the emergency room because they may need to be intubated. But if they're doing well after half an hour, then they're doing well, then you consider how you assess them for being discharged, and you would also look at stepping them up on their therapy because they've had their exacerbation. So they've improved with this exacerbation, but you're now looking at maybe they were on step 3 and you need to move them to step 4, step 5 as they continue their prednisone pulse dose and come in for a quick follow-up visit within the next week or so. Okay, maybe sooner than that if it's severe. In more severe cases where the patient's assessment is warranting that they go to the emergency department, then anything that is significant in their presentation, particularly if they start to look like their oxygenation is poor and they're having all those severe symptoms, those are folks for whom you have to stop and think, this patient may need to get intubated. But our approach typically in the emergency department is we start them on short-acting beta agonists by nebulizer, often with ipratropium, so it's usually Duoneb. We put them on oxygen. We give them corticosteroids. In the emergency department, while you could give oral corticosteroids, almost always we give methylprednisolone. The other two things we routinely will start, even though the data is maybe not perfect, is IV mag sulfate. Pretty common to see that done. It probably offers no danger or harm other than maybe rapid administration causing hypotension, careful for that, or maybe IV irritation at the vein. But it's pretty common to give IV mag sulfate in emergency departments because there's some data to suggest for a subset of patients it may help with that bronchospasm. And then consider higher dose inhaled corticosteroids, but to be truthful, if you're really severe, high-dose inhaled corticosteroids are not going to do much. You really need systemic corticosteroids. They are continually being assessed for disorientation because you may need to intubate them and send them to the ICU. As you're looking through that, you continually assess them, and if they are really in dire straits, we will look at intubation for that patient. Okay, as you look at all these guidelines, try to get the gist of it, the themes involved, how we layer on therapy. Here are some of the more common drugs you'll see in practice.